end of the presentation. It's also being recorded. As you know, that just started too. Participants will receive a 1.5 CME or CE units for the webinar. So to receive the credits, attendees must attend the full session and complete the evaluation to receive credit. So partial credit will not be granted if you don't do that. If you've joined by calling in, please let Quinn or Bao know by emailing to continuingeducation@caloptima.org in the inbox for credit. Secondly, you have to just complete an online course evaluation. So please allow time after the training to complete the evaluation. Evaluations will be displayed or popped up after the attendees end the training. If for whatever reason, if you missed the survey at the end of the workshop, we will send a follow-up email by the next day, and you can click on the online survey in the email to complete the evaluation. So that's really important for us. I think also a part of that evaluation will have a question about other topics or webinars that you would like to see, and that's very important for us to gather that information. CME certificates, they'll be sent out via email after you complete the evaluation by UCI, School of Medicine Continuing Education Office. Please just allow up to 8 weeks to receive it. So CE certification for BRN will be sent via email from CalOptima, Population Health Management Department, after you complete the evaluation. Please allow up to 8 weeks also to receive that. And then lastly, a recording of this proceedings will be produced within weeks, and we will include a PDF copy of the presentation slide deck. And so now I'm very excited to talk a little bit about our speaker today. So Paul is a licensed clinical social worker in California. Here you are, Paul, welcome. And he has over 18 years of experience providing mental health services to mild to severe, persistent mental illness and addiction. In addition, he has over 15 years of experience organizing community mental health conferences focusing on mental health care for Asian and Pacific Islander communities in California. Subjects of expertise include severe persistent mental illness, grief and loss, cultural and intergenerational trauma, integrative treatment approaches, emergency mental health and disaster response, spirituality, mindfulness, cultural sensitivity, community and program development, professional conference organizing, media relations, publicity and campaigning, outreach and engagement, logistics, and coalition building. Paul also is a missionary for 7 years, working in and outside of the United States. He holds a master's in social work from Loyola University in Chicago in 2006, my hometown. Also works to continue to produce micro, meso, and macro level impacts. He's also the founder and president of Viet Care, Vietnamese Community Actions for Resources and Empowerment, a nonprofit organization developed in 2008 to reduce mental health disparities and enhance quality mental health care services. So it's my honor to pass this off to Paul. Thank you so much for being here today. So look forward to your presentation and training.
Well, thank you very much, Carmen, for this opportunity. I want to take this moment to thank you to CalOptima, Dr. Thanh Tâm and Carmen and the whole CalOptima team for putting this together and organizing this for the community. Since this is a training, I invite everyone to turn on your video for this moment, and just so that we can have a name and a face to each other, so that we can have this sense of community, right? We are talking about suicide, crisis preventions, and the worst thing for someone who's experiencing suicide and crisis is feeling invisible. So I encourage everyone to turn on your video and join as a community. And I'm going to share screen right now real quick, and then we'll go into the program. Okay. So as Carmen shared earlier, this is September. It's a National Suicide Prevention and Awareness Month. So I'm not sure if you are aware as of 2021, for every 11 minutes, we have one person die from suicide. And so for that reason, I would like to invite everyone to spend 1 minute and 11 seconds in silence to remember those who have died from suicide, as well as those who are impacted by suicide, by the death of someone from suicide. And if you feel comfortable, you can go ahead and put it in the chat room or unmute and say the name of the person that you want to honor and remember who have died from suicide. And we'll begin that moment of silence now. Thank you, everyone, for honoring and offering up that moment of silence to pray, to remember all of our dear friends, those who have passed away due to suicide. And as we are aware, not every suicide is due to mental illness. And September 11 is one of those situations that forever is ingrained in all of our mind. How the images of people jumping off the building, it is an act of suicide, but it is not due to mental illness, but due to extreme fear and anxiety of being burned or being killed. And in that moment where individuals jump to their death, it is something that's forever impacts so many of us, especially those of us in this country. So with that, I invite you again to give yourself permission to be here in this present moment, to be able to not only honor those who are experiencing challenges, mental health challenges, or situation in life that may lead them to contemplate suicide or homicide in terms of mass shooting, or those who are experiencing mental health crisis wherever they are. This is the stats from CDC, as what that first slide was about. About every 11 minutes, there's one death in the US due to suicide. So I invite you to visualize wherever you are at this moment. If you were not at this training right now, where would you be? Are you in the clinic? Are you at the hospital, outpatient, working in the field? Or at home, if you're working from home. So wherever you are, visualize yourself at that moment, wherever you may be, and this happened.
Honey, what should we do? I don't know why Sammy's like this now. I'm worried. She hasn't left the house for 2 months. She hasn't even showered for weeks. I mean, she's not even acting or looking like herself. She's not talking to anybody. I'm worried something might have happened at school, but she won't tell me why she came back home to stay with us. Hello, do you hear me? Say something.
I'm not deaf. I'm worried too. It's not like you're the only one.
I'm the one who has to hear her crying every single day. Can't you talk to her? You've always been closer to her. She won't say anything when I try to talk to her. She just freaks out and screams at me to leave.
You think I haven't tried? She's shutting me out too. Do you know how many projects I'm behind at work? Why don't you just look up some resources or something for her? She'll be fine.
I knew you'd say that. All you care about is work. Don't you see what's happening to her? She's 22 now. She was always a straight A student before. All because you've never had to worry about her before. But now can't you just show that you care a little?
If I don't focus on work, where will I get the money to pay the bills? I might lose my job and then all of us will end up like Sammy. I don't know what to do with her. You deal with it.
Okay, so that's the situation. What would you do? Wherever you may be, right? Whether as a first responder, right, an ER physician, a family doctor, a therapist, outpatient or inpatient, or a friend or family member, and you are interacting with either the mom, the dad, or the daughter, with this situation, what would you do? By show of hand, if you can go ahead and click on your emotions the thumbs up, if you can relate, or if you have dealt with situation that is similar to what you just heard. So I'm looking at the screen of all the participants and I see several people have raised their hand, right, indicating that this is something that you may have experienced already or possibly experienced at your workplace, home setting, social setting. But this is something that's very common, especially since the pandemic. I just came back over the weekend, spending 4 days in Orlando, Florida, to do training on crisis and suicide prevention and training similar to this, to the Vietnamese community over there. And so many share how the youth over there are also in crisis. The families, the relationships have deteriorated since the pandemic. And more needs for crisis responders, especially culturally competent and linguistically able to be able to do so. So with that in mind, what would you do? And I hope that's the reason why we're all here today, to be able to either explore, discuss, hopefully enhance, learn something new, or enhance what you already have, to empower you and enable you to be more effective in doing crisis interventions or de-escalation, whether at the workplace, home place, or even in the social setting. Keep in mind that the skill that you develop or the knowledge that you obtain here is not limited to only at the work setting. So crisis does not discriminate, and so it can take place any place, anywhere, anytime. So having this skill set and this knowledge will be able to be helpful if you decide to use those skill set. I want to thank Carmen for introducing me already and my background. I want to share this image real quick about who I am, and this image kind of capture my history, where I was and where I am today. The picture, top corner right here, a house made out of mud. It is almost the exact house that I grew up in Vietnam. I still remember helping my dad stomping the straw and the mud together to compact and fill in the skeleton, the framing of the house using mud. And then in the late 80s, I escaped Vietnam as a refugee on boat with 27 men, women, and children, and spent about 30 days in the ocean, where we experienced pirate attacks by Thai pirates, starvations to the point where there were discussions of killing one of the men who was sick, or the sickest person on the boat, so that they can feed him to the rest of the people on the boat. Unfortunately, that did not happen. My dad kind of intervened and put a stop to that because he was one of the leaders on the ship. And then the bottom left corner here, this pictures and this image here means a lot to me and to a lot of people. All gave some and some gave all. The sacrifices that is given for freedom. And with great freedom comes responsibility and accountability. And so the freedom that we have here to be able to learn, to be able to interact and connect, freedom of speech, and the choices that we make on a daily basis have an impact, not just on our own life, but those around us. So how do we go around to contemplate and decide what we do, how we do it, when we do it, to bring about positive impact in life and those around us. And because of my journey, I'm able to be where I am today. I'm able to go and present throughout the states, and recently now I'm going outside the state to do training and sharing my own personal story of suicide, as well as the training that I've had and experiences I've had for over 16 years working as a first responder with the CAT team, the PERT team, with law enforcement, and then now under my own agency is moving forward. This is a disclosure. All individuals in a position to control content for this session have indicated they have no relevant financial relationships to disclosure. Hopefully this is going to be an interactive training. So if you can lower your hand if I still see hands raised. So unless you have a question, you can go ahead and lower your hand. If you can stop me at any point if you need me to clarify or explain any aspect of it. I hope for this to be an interactive session rather than just a presentation. Okay. So at this point, I'll ask Quinn or Bao if you can go ahead and start the poll. If you can, go ahead and take a minute to answer these 3 questions, just so for us to know where you are today and what type of knowledge you want to obtain or enhance at this training. So we are asking to see of knowledge, skill, and attitude to be able to see how we can best make this training as relevant to you as possible, so that the time that you invest here right now will be productive for you, and that the information you obtain can be relevant and useful to you after the session. At any point, if I'm speaking too fast or not clear, please let me know in the chat and I can slow down. All right, we have about almost 50% of the attendees responded already. So we're gonna give maybe just another minute to see as many respond, and then we'll show the result. So right now, out of the 354 participants at this training right now, we have about over 200 respondees already. So we can go ahead and end the poll and then show the result. I'm not sure if you're able to see the result. Can everyone see the result of the question? Oh, so it's just me that can't see. Okay. So I'll go ahead and proceed. It seems like some are only able to see their own answer. So hopefully one of the admin here can look through the responses real quick and be able to pick out some of the common knowledge, the most common responses for the knowledge, skill, and attitude. And then I hope my goal is to be able to integrate that into today's discussion. And then if you have anything, you can put it on the chat box as well. And then if it's relevant to the moment of the slide, I can share that. If not, we can table it to the end during the Q&A session. Okay. Okay. So this is the outline for today's presentations. I will share with you what the API crisis response model is, the three phases of it, and then we'll end with the debrief or the sharing. So API here stands for Active Prevention and Intervention Crisis Response Model. It is a model that I've developed back in 2019 after years of working with the CAT and PERC team and with law enforcement. And I was able to reflect upon the experiences that I've done in the field and analyze which have been effective and not. And so from that, I've developed this API crisis response model. A stands for active. So active here is you being actively aware, actively assessing, actively anticipating, and then you act. And then the prevention, the P here is for prevention, and then the I, of course, is for intervention. And then we'll go into those sections. Okay. So with any crisis, let's start with yourself. So if I can ask to make this more interactive, if anyone here can either unmute and respond or type your responses in the chat box here. How does self here, what role does the self play in a crisis? How does crisis start with the self? Someone just unmute to answer. Please go ahead.
I would
I
say
think
it's sorry. I would just quickly say that it starts with like that internal dialogue, because maybe what a clinician considers a crisis might not be the same as someone else.
Yes, exactly. Great job, Ashley. So your own internal perception, right, and understanding of a crisis may or may not be what is the situation that you are encountering. Go ahead, Elham. Go ahead. You can unmute and respond.
well, I'll wait.
I think
No,
the
go ahead.
individual's, yeah, the
Oh.
individual's perception of what the crisis is.
Yes. So that's that's going to be the next slide. One, it's the awareness of the other. So for this slide, we're talking about yourself. Like if each of you were to be responding to a crisis or encountering a crisis, what is it about yourself?
Well, staying calm, I would say, is really important.
Okay.
I was going to say the exact same thing. If somebody's in a crisis and we get taken by our own emotions, how can we calm somebody else if we are, you have to calm down, you have to calm down? Well, the person will not calm down if we see. It's kind of like the calmness is contagious. So you kind of have to control all yourself and your own emotions in order to assist others to control their emotions. Like in an airplane, you put your mask of oxygen on you first before you can help others.
Excellent, great response. And that is very true in a state of crisis, that the responder needs to be calm. So whatever level of anxiety that you bring to the situation, it may escalate or help de-escalate the situation. So we're talking about emotional regulation for the self. Right. I love some of the responses in the chat box here, especially the one that's talking about your bias, your background, your prejudice. So how you're able to communicate, your form of communication, right? How you deal and react to situations, your mindset, your internal dialogue, your empathy, your self-control. So all of this is great because this is you starting with yourself. Oops. Okay. So when we are starting with ourselves, we're talking about awareness. What level of awareness are we of our own internal responses, of our own internal biases, of our mindsets, everything that's about ourselves? Because the moment we leave our comfort zone, our office space, wherever that may be, or our comfort moment, and then we engage in a crisis. And if we are not aware of what's going on internally and be able to regulate or manage that, then it may come over and affects the crisis itself. So here are some of the aspects, right, that people have already responded both in the chat room and share out loud. So your implicit bias, right, your own trauma history, your own cultural humility, right? Scope of work. So I'll share a little bit your capacity and your location. Can someone here share a little bit how does implicit bias affects the crisis situation, whether it's to escalate or de-escalate a situation? And you can raise your hand and then respond. Let's see, Irene, Alba.
What is the question again?
You have your hand up, so I'm not sure if you're ready to answer the question. It was, how does implicit bias impact negatively or positively a crisis situation?
Just by observation and listening to the person that is in need of some kind of physical depression, emotional.
Yeah. So here we're talking about our own implicit bias as the providers or as the responder. I have a very concrete example back when I was working with CAP as a supervisor. One of my staff shared with me that when the staff brought the patient to a local ER for admission on a 5150, the ER physician at that hospital made a loud statement about the clients that the CAT staff was brought in. And he says, like word for word from what I remember, he told his staff to not hospitalize the individual who was an identified female or lesbian. And his statement was that that's just how gay people act. And here, this is a situation where this individual was placed on a 5150 by CAT staff. She was experiencing severe manic episode and was in danger of hurting herself, going in and out of the traffic. And because she was wearing very colorful clothing, very colorful hair, and when she went into the ER at that time, she was very happy, very jovial, and all the symptoms of a manic phase. But the physician made that comment. And so that's the implicit bias from that particular provider here towards individuals who are LGBT, impair his ability to connect with his clients, impair his judgment as well as his ability to work with his team. And how, if we were to be on the other side as the person receiving the services, how do we perceive that experience? Will we want to go back to the hospital? Will we want to get help at all? If that is our experience of a service provider. So that's one example of implicit bias, how what we feel inside about certain situation, about certain individual can impact our outcome. Another implicit bias that is often shared among first responders, especially, where people, when they can become either jaded or start generalizing, they would often say, oh, this is just another drunk. This is just another drug addict. That statement and that mindset prevents the individual to really do a thorough assessment and see the individual for who she or he is at that moment. So it's important that when we go out and respond to a crisis, whether it's out in the field, at our own office, at home, anywhere else, that we have to be able to check our own implicit bias and be able to become aware of it, so and see how that impact the situation. In terms of trauma history, as the providers, right, or as a community members, as clinicians, many of us, some of us, right, have our own history of trauma. How does our trauma history carry out and impact the situation? I can share my own example. As a refugee, I was not aware that growing up I had PTSD. I did not know that I had major depressions. And so during that time, and whenever I see a Thai person, my face and my head would go very red. And the automatic thoughts that came in my mind at that time was that I want to kill that person. This rage came over me every time I see a Thai person, and I didn't know why. It wasn't until years later when I went through treatment and became aware that I had PTSD, that due to my experience as a refugee, being attacked by Thai pirate, I've developed and that image or that perception that all Thai people are bad, and that Thai people are the one that cause us to or harm us during our experience. So that rage and the anger was projected upon all Thai people. So that's one example of our own trauma history, whether it's as a refugee, and especially in Orange County here, when we are working with immigrants and refugees, whether it's from the Vietnam War era, from the Iraq, from now the Ukraine, coming to Orange County, how does our trauma play a role? Sometimes I have the flip end side, where I know provider who have their own trauma, and because of the trauma that she experienced, she overprotect others, right, and hospitalize everybody, whether they meet the criteria or not, for 5150, because she wanted to protect them from whatever situation that may be. And so we may become overprotective of individuals in a situation that may not be warranted. The next concept here is cultural humility. How does our awareness of our own cultural humility different from cultural competency? Whereas cultural competency is we're trying to measure how much we know about someone's culture or about our own culture. And I can't say for others, but I can say for myself that how can we measure cultural competency? How do we know how much we know is enough? And so shifting from the mindset of cultural competency to cultural humility give us this mindset to be able to be open to learn, that we don't know enough. So because we have that mindset of not knowing enough, then give us that opportunity to allow others to teach us, allow us to frame our mindset and now frame our question so that we can ask open-ended question rather than make an assumption about someone's culture or our own. And so that's something that we are able to connect, especially when someone's in a state of crisis, is ask them question to be able to open up rather than making an assumption of because of their cultural background. Okay. So we have 4 hand raised. I'm not sure if you have a question with Elham and Irene, Vilma, and Cecilia. If you have to raise your hand to ask a question, please go ahead and then unmute and ask. If not, lower your hand. Yeah. So there's a question that's in the chat box. What about explicitly acknowledging our cultural humility? Rosanna, can you clarify a little bit about the questions? What do you mean by that? And if you can expand on that. Yes. So it is a good idea, at least from my experience in working. I'm not sure the age range of those who are in this room right now, but for those who remember the TV show Columbo, right? He has a great way of getting individuals to confess their crime and be able to give them the information that he needed. And the main strategy that he used is playing that dumb card that he doesn't know, playing that confusion card. And so cultural humility is, in a way, accepting our own limitation. Even though I am Vietnamese American, I cannot say that I know everything about Vietnamese. I left Vietnam when I was 7 years old as a refugee. And so I know for a fact that my cultural awareness is not as deep as someone who grew up in Vietnam and come here recently, for example. At the same time, for those who grew up in Vietnam and came here recently, they too cannot assume that they are more culturally aware, because culture is organic. The culture of Vietnam back in 1975, 1980 is very different from the Vietnamese culture now in Vietnam of 2023, or the Vietnamese culture here in the US and in Orange County of 2023. And so culture in itself is organic. And so for us to make that assumption that we know, right, put us at risk of making a mistake. especially in a crisis state where if we come across as making assumptions or presumption about somebody, it may be a turn off and it may lead someone to be more guarded and closed off. And so in a state of de-escalation, in a state with the intention of de-escalation and crisis interventions, ask an open-ended question, asking clients to teach us, to help us better understand, is in a way allow us to be able to get deeply connected to the client, but also allow the client to explain and release the stress, to be able to externalize their internal pressure, whatever that may be, whether it's the frustrations, the anger about themselves, about others, about the situation that they're experiencing. And so asking those open-ended questions can really help individuals to open up rather than being closed off. And then in terms of crisis and awareness about capacity, just before this training, I received a text message from a client of mine who happens to be unhoused or homeless. And in that text message, she mentioned that she's needing help right now, that she's worried and concerned that she's going to do something bad to herself. I know right now at 12:30, I have this presentation, so I cannot just leave, right, cancel this training and go. And so in terms of capacity-wise, physically, I cannot be there to respond to my own clients. Emotionally, I cannot be there either, nor psychologically, because I need to be focused here. And so what I ended up doing is, with that brief time before this training, I met up with one of my staff who does the street outreach program. And so I connected with him. I shared with him the briefing of the dynamics. And fortunately, this client is someone that my outreach worker has also been working as well. And so sharing with him the concern that she just raised in a text message. Now, I'm passing on because I know my limitation, my capacity right now is I have to be here, present here. And so I gave my staff the instructions and collaborating with the Be Well team of the city and the police if necessary to be able to go out, build rapport, establish that we increase the rapport that we already have with her and explore what's going on, what dynamics is triggering or putting her in a place where now she's worried that she may hurt herself. And so that's the capacity that we have to be aware of even before I respond. And then location-wise, I cannot respond to someone else or somewhere else where I am here physically at a different city. And so if I know that location-wise I cannot respond, I have to refer out. I have to connect to someone who's local, someone who can respond at this, as soon as best. And so that's the awareness that we need to be able to have, to be able to, even before we go out to respond to a crisis. Right. So if Quinn or maybe anyone from admin who's monitoring the chat room, if there's any comment that you want to share, you can go ahead and read them out. Okay, and then for those who have questions, feel free to continue to write it in the chat box or raise your hand, and then we'll call on you. And Nam Dong, do you have a question? I see your hand raised. Okay. Thank you very much. Nadia in the chat box have shared that information and awareness is extremely important. This is the only way that the stigma can be avoided. Understanding that this can happen to anyone and any family. Okay. Can you touch base on emotional capacity again? Yes. So emotional capacity, I can share my own experience, and if others who have experienced it, I invite you to also share, unmute yourself so that we can have an interaction and a dialogue, share your own experiences or challenges. So emotional capacity, if I'm too preoccupied with something, for example, and I cannot be fully present to assist someone who's in a state of crisis, then my capacity is very limited. And so I need to be able to be honest with myself and ask, am I the best person to respond or handle the crisis when emotionally I cannot be available? Right. I take, for example, when I was working with the Psychiatric Emergency Response Team, or PERT, with the local police department, In one day, I had 75150. It was back to back. The last one involved a bomb threat, where we entered a home and I had to help de-escalate the situations out from outside before the police secured the premises. Emotionally, I was drained because that whole week of work, I did not eat at all. For that whole week, I was going back to back call every day that I was working. By the time I finished my shift, I went home and I just crashed. And then the next day I woke up, I go back to work again. And that same work schedule was so busy that particular time that physically I was not eating for almost that 4 days that I was working. I was working 410. That 4 days I wasn't eating. And emotionally, I was so drained from responding to 5150 back to back every day, those 4 days. That I know that on the last day, I was not able to get my full self. If I knew what I know now, I would have asked and called for outside assistance to be able to assist with that crisis. The challenge that I experienced at that time, and I can imagine other first responders will experience, especially those who really take pride in their what we call the beat or in their assigned city, is that that's my city, I'll take care of it, right? That's my beat, I'll take care of it. And so that pride that we have to be responsible to take care of everything that's there sometimes put us over our capacity. And so in terms of self-care, in terms of balance, work-life balance, in terms of being fully present and at full capacity, at the best capacity to help our clients, I ought to have called for outside assistance, either other CAT team to come in to support those call rather than taking all those calls myself. And so at the clinic at the same time, or outpatient right now, if you as a physician is going to go to do a surgery or at the ER, whatever that you're doing, and you're mentally, your capacity at very limited already because of your responsibility, are you the right person to go out and do a crisis? Or is there someone else in that system of care that you can rely on? And if within your system of care, if you are unable to, you have no one available to because of the capacity wise, can you contact the CAT team? Can you contact the PERT team? And now with Vero City in Orange County, we have what's called the HOPE team, the Be Well HOPE team as well. So there are multiple programs out there that can be available to assist the clinic as well. And so we don't have to just think that we are in this alone. And I think that's the biggest takeaway I'd like to share with you, is that it is very critical to know that you are never alone when you are in a crisis or when you are responding to a crisis. Because the moment you think that you are alone responding to a crisis, all of that pressure comes on. That is not healthy. And we are also not maximizing all of the resources that we have to be able to assist our clients or that situation. So that is all for about awareness. Earlier, we talked about awareness of others, right? What is it about the other that we need to be aware, even before we make the engagement? How do you increase your awareness about that person, that situation? Right? For first responders, I train them to be able to, before the days of the GPS, right, where we have the map, we have to read the map, we have to know the location, the neighborhood of the call, so that we know where our exits are, our entry points are, and then where we should park for safety when we engage in a crisis. The other part is to be able to understand, right, that dynamics of that neighborhood. If we don't have access to the information, you can always call the local law enforcement department, right? If you are the one, if you are psychiatric first responders, or if you are responding to your own clients at certain locations, if that location is new to you, what I have done in the past is I would call the local law enforcement department. I would identify myself. I would let them know what was my intention to go into that neighborhood or that locations. And in law enforcement, it's called an agency assist. And so I am calling them to be able to ask for assistance. And part of that assistance is I'm asking them for what we call history location. Can you give me the history location of that house, of that resident, of that neighborhood? Is there anything dangerous around that neighborhood, that house that I need to be aware of before I engage and go to that neighborhood or that location? This has happened when I was overseeing the CAT team, where my staff who work at nighttime responded to this particular detox center in South County. At that time, none of us knew what was going on or the information about sovereign citizens. And so when the CAT staff approached and arrived at that particular detox center, and she waited for the police to arrive, just as that's our normal standard protocol. When the police arrived, there was 3 units that arrived. And when they arrived, they told our staff to come with them and drive with them off-site to another location and wait for another 2 or 3 units to come before they even engaged that particular facility. The reason for that was because that particular facility is run by sovereign citizen. Sovereign citizens is a group that is anti-government. So if you come with a government badge or with law enforcement, there are chances of increased physical danger because they carry a weapon. And so those are things that the normal person would not know unless you are working in law enforcement or in crisis in certain area. And unless you call the local law enforcement, identify yourself, and they will verify that you are who you are before they disclose certain information. But that's also a part for you to be able to build that relationship with police officers. And when they respond, they want to make sure that you are safe when you do respond to any crisis, so that they don't have to respond to you experiencing crisis. And then also, I guess Kathleen is very accurate insofar as being aware if they are hungry, if they're angry, if they're tired, if they're overwhelmed, right? Either you yourself can shut down if you experience that yourself, or if the client who's experiencing that crisis is going through that experience, then we need to meet that basic needs first. So sometimes when I go to clients in a crisis, I always have some snack or some water with me, especially clients who are out in the field, who are homeless. They may be dehydrated. They may be hungry. And so that snacks or that water can be that bridge for me to be able to connect with them, to be able to let them know that I come bearing gift rather than coming as a threat. So meeting that and becoming aware of that is the same thing. It's the same awareness about ourselves as it is for the other person. Does the other person have any implicit bias, right, against you that may impact the outcome or the process of the de-escalation? Do you know if that person have gone through any history of trauma? And if so, what type of trauma? How would that contribute, negative or positive, to the interaction with you? And then the cultural humility. Do you know the other person's cultural background? If they are immigrants or refugees or asylums, those are different mindset, different situation that brought them here to the US, to our community. And refugees, especially for the Vietnamese community, I'll share in the slide later, there's different waves of refugees and immigrants that's Vietnamese. And the language. Language plays such a key role in being able to open up, to be able to connect. When I was still working with CAT, and at the same time, I was also working part-time at an inpatient hospital, where I received this patient. She was Vietnamese speaking. I was the only Vietnamese speaking staff there. She was brought in the night before. So when I started my shift, and they waited for me to do intake with her. When I interviewed her, I became so angry of what had happened to her. The circumstance was that here is a Vietnamese speaking woman who was placed on a 5150 by a local law enforcement officer. What happened when he responded to the call was that the neighbor called saying that there's a naked woman out in front of the street yelling and screaming. When police arrived on scene, because this woman did not speak any English, the husband came out, and the husband introduced himself and spoke to the officer that she's crazy, she has schizophrenia. Don't listen to what she says. She's just rambling and not making any sense. And because of what the husband has informed the officer took his word for it and hospitalized her under the justification that she was psychotic. When I interviewed her, the information that came out, she was coherent, she was organized, because I communicate with her in Vietnamese. What she shared with me was that her husband married her from Vietnam, brought her from Vietnam over to the US. The moment she arrived in the US, he locked her in a shed in the backyard. After locking her up in a shed in the backyard, he uses her as a sex slave. He would pimp her out for different people to come in to rape her over and over again. One day she was able to break free and ran out. And she was in the front yard yelling, screaming in Vietnamese for help. And she was cussing and yelling at the husband who was coming after her. But no one understood what she said because she spoke everything in Vietnamese. And the officer who was there on scene did not speak Vietnamese and trusted the husband as a translator and hospitalized her. Whereas this was a human trafficking situation. And so this is the important of the impact of language. If you don't speak the language, it's important to find someone who can to collaborate with, to be able to be either on site or over the phone. And we know in working with law enforcement, when we ask for a translator, oftentimes we don't ask the friends or their families to translate because they will either minimize or embellish information to protect the families or the friends. And so to find someone who's objective, to provide objective evidence and collateral information, we need to have an objective person to do the translation and interpretation. And so that's when we talk about cultural humility, but also culturally adaptive and linguistically relevant, right? Approaches to work with individuals in a state of crisis. Otherwise, we can escalate or misdiagnose and end up doing mistreatment for it. Take, for example, I'm going to go back for trauma history, for example, and language, which is a cultural, this three-part right here that involved me when I was working with crisis. I responded to a situation that would involve a 5 hours standoff with the subject of the woman barricaded herself in her house. The reason she barricaded herself was because the sheriff came with a warrant to arrest her. And it was only for a traffic ticket. The sheriff did not know that this woman has agoraphobia. And so she was terrified of leaving her house. So the first time the sheriff came to arrest her, she slit her throat. Because she told the officer that if you take me out of this house, I will slit my throat, and with the knife. And the officer, the sheriff, the deputy did not believe her because he said, this is only a $500 ticket. It's not worth for you killing. Just go to the court, deal with the judge so that I can let go of this ticket and this arrest. He was not aware what agoraphobia is. And so when the moment he grabbed her hand to arrest her in the front door, she slit her throat. So the second time, years later, a different deputy came for the same warrant, tried to arrest her. But this time, the deputy read the prior report, and was able to not make contact because she refused. And so long story short, local law enforcement came out, did a 5 hours barricade to try to get her out. Finally got her out through tear gas and beanbags through the back entrance. And she was de-escalated. She was strapped on a gurney. She was ready to be taken to the hospital, but they needed me to evaluate her to write the whole. Not knowing who I was, the moment I approached and she saw me, she got up out from the gurney. She screamed, and forgive my French. She said, "Fuck that." She said, "That fucking Asian." Right? She pointed at me, and she was so angry. She was so angry, and she acted. And so I did not know I triggered her. I triggered her because what I learned later on, is that she lost her job, and the person who replaced her happened to be Asian. Since that incident, her perception was that all Asians were bad. And so when she saw me and I responded to her, I triggered her and made her to become more aggressive. And so that's the other part of the awareness that's important, that when we go out to assess or to de-escalate, we have to ask a question to help us understand, is there anything about this person that may trigger me? Or is there anything about this person and the situation where I may be a trigger to them or as well? And so those are the awareness that is important for us to be able to pay attention to when we de-escalate or provide crisis interventions. And capacity, physical, emotional, psychological, is the same thing for the other person that we're working with. One of the situations that I responded to also deal with in the past with APS, with sheriff, as well as the landlord coming out there to try to evict an individual, a paraplegic, out of the premises. And because they could not get that individual to leave, they contacted me as a CAT team at that time to go out to hospitalize them. As I was approaching that apartment, I could hear all the yelling and screaming. And it was all from the sheriff, from the landlord, from the APS worker yelling at the client. And I was very perturbed. I was like, what's going on here? So I stood outside just to listen to what's going on. And then when I came in and I asked the sheriff, has the individual been checked if they have any weapon on them? And so he said, he's clear. So the moment I got confirmation that physically there's no dangerous items around that could be a harm to myself, I cleared out everyone from the room. I asked everyone to leave the room and just me and the individual. If this training was in person, I could show you what happened, but because it's virtual, I invite you to imagine this. So the person who was paraplegic, he was on the floor, right, with a towel, with a blanket around his waist. And before I came, the sheriff, the APS worker, the landlord was all standing over him, hovering, looking down on him, yelling at him. Imagine how that impacts you if you were the person experiencing crisis. And so what I did was I sat down and made eye contact at his eye level. And when I did that, he looked up and he told me, this is the first time for the past 10 years where someone spoke with me at my eye level. Physically, he was not able to move because of his condition. And the story that he shared was even more heartbreaking. He was a multi-millionaire. On a Friday evening, after walking home from a pub, he saw a man that was getting jumped, getting beat up by a group of teenagers. He decided to come in and help the gentleman. And in that act of helping this gentleman, he got punched and he fell and his back cracked on the curve of the sidewalk, leaving him paralyzed from waist down since then. And over time, he burned through all of his saving, all of his money, leaving him to the point where he's now living in a multi-million dollar home to an apartment where he can't even afford now anymore. And so someone who was doing a good Samaritan deeds got injured and become physically incapacitated, emotionally and psychologically vulnerable and angry, and experiencing that crisis, and individuals coming in with a different mindset. So it's very important, again, to be able to be aware of that individual. Okay. So those are the things that we need to be aware of when we make that crisis intervention. And then, of course, in the process in between, when we are aware of ourselves, when we are aware of others, when we're interacting, we're only paying attention between the person and face to face. We don't pay attention to the spaces in between. That spaces in between, or that space in between, is critical because that's an indicator of how close you are, how connected you are or not connected you are. That space in between also represents the process through which you're trying to connect and help somebody. So pay attention to how you sit, how they stand, and how you engage, as well as all of those around during a crisis. Because when there's a crisis, especially out in the open, there are people who are holding cell phone recording. There are all these bystanders. There's law enforcement. There's so many different factors around you. There's staff. There's family members. There's dogs around. So as a first responder or as a crisis responder or responding to a crisis, it's important for us to be aware of all the spaces that's in between us and the individual we're trying to help. Because that awareness is critical for our safety as well as for the effectiveness of the outcome. We already went into culture already. I'm going to share really quick about the Vietnamese culture. Here, this is a history of of wars within the country of Vietnam. We were colonized, right, over 1,000 years by the Chinese, with over almost 1,000 years of independence, followed by 100 years of French colonizations, and then the 21 years of the Vietnam War, right? From this history of war and the climates, the religion, 85% being Buddhism, 8% Christianity. How does culture, religion, spiritualities, and that history of colonizations, of war, impacts our cultures and our responses to certain dynamics? And in terms of migrations here, this is an image, right, of the different migrations of Vietnamese to the US. Even though it's documented the first immigration wave is the refugee after the war, 1975, there are documented Vietnamese American who live in the US as early as in the 60s. One of my clients, my former clients, she was one of the first Vietnamese psychiatrists living in the US, and she came here in 1964, right? So those who came to the US as refugees, so refugee comes with a different type of trauma, different type of experiences. Those who come by airplane, by the family unifications in the late 80s and 90s, and then those who come recently, right, in terms of sponsorship. So different wave of migration comes to reflect the different part of the cultures and awareness. So with the stats right here, I invite you to visualize if you have a 100 patient come to your clinic, and 8 of that patient or 8 of that clients who come in made the same complaint, what would you do about that complaint? Would you just take it and try to investigate and try to help it, make changes that needed? Or you say, oh, 92 others are happy, so we don't have to take care of the 8, right? What if it's the reverse? What if it's 100 patient that comes in, 75% complain? Would that data inform you to change your operations or your way of interacting with clients? So this data here is actually not any of that. This data here represents depressions. So in the US, this is the data from the National Institute of Mental Health from 2020. In the US general population, 8 out of 100 individuals has a diagnosis of depressions. Whereas for the Vietnamese refugee, it's 75 out of 100 who has a diagnosis of depressions. Similarly, when we talk about this stats, and which is for PTSD, in the US general population, 6 out of 100 has PTSD, whereas for the Vietnamese refugees, it's 50 out of 100. So understanding that history and to go back to the history of war and colonizations of the Vietnam and the refugee experience, migration experiences. And then here we have the data that shows how there are 75 out of 100 Vietnamese have a diagnosis of depressions, and 50 out of 100 refugees or refugee history origin has a PTSD component. How does that inform you of interacting? So that's where we talk about, that's where we should talk about trauma-informed care. Right? That's very similar to cultural humility, but here when we talk about trauma-informed care, we understand as best as we can of how trauma impacts the individuals and their responses. And so instead of making an assumption, we ask them to help us to understand how does this situation impact them. and what factors in the past or in the environment has contributed to the current experience of the situation. And so going back to the API crisis response model, A here, right, the first component, the first phase, actively aware. We need to be actively aware of ourselves, our internal processes. We need to be actively aware of the others, of our environment, of the clients that we're working with, right? We have to actively assess all the time, not just one time. We have to always actively anticipate what's going on so that we can act appropriately. All of this, first and foremost, is to ensure our physical safety so that we don't put ourselves in harm's way, so that we can become aware of what are some potential barriers. Is it internal barriers, our own, or is it barriers from external factors, from the clients or from the environment? This awareness can also help us to become more aware of our internal resources. What available resources do we have? Is it internal? Do I have the ability to validate, empathize, active listening, redirections, right? So all the skills that we have internally to help this individual, those are all considered internal resources. Any other resources outside of us are external resources. So we need to be aware of what resources are available for us to be able to assist this individual. And then finally, it's about the role and collaborations. To go back to the comment I made earlier about we are never alone. So it's important to be able to look at who else needs to be involved, who else can help. Okay. And then the prevention part here is similar, right? In understanding and being aware, that prevention part is to build rapport. Genuine, compassionate, hopeful, right? Non-judgmental. Help the client to know that we can relate to them, that we have a genuine interest in their situation and in helping them. And so that's how we can respond with care. Care here is compassion, acceptance, reassurance, and empowerment. How can we demonstrate that we genuinely care and show compassion? How can we genuinely demonstrate that we accept this individual for who he or she is, where he or she is at in life, so that we don't cast judgment? How can we reassure this individual that things can get better, that we are here to be able to walk with this individual through this process? How can we empower this individual to take action to help themselves so that they don't become reliant or dependent on us or on the system, right? So individuals need to be able to overcome, because the bottom of the denominator for crisis or for suicide is hopelessness, powerlessness, helplessness. And so if we can empower them with hope, empower them with choices, empower them with options, then we can help them, elevate them to get out of that sense of crisis. And then for the risk assessment, for the intervention piece, is again, we're assessing for risk, assess for we're doing intervention to empower them. We're intervening to help them feel safe, to offer them a safe place, to help them regulate their emotions and manage their emotions, and then develop the resources that's needed, both internally and externally, for them to be able to better manage the crisis. And so the risk assessment here is the equation that I developed years ago when I did the 5150 training, is that symptoms, when we assess for crisis or risk, we look at the individual symptoms, their behaviors, the level of impairments. And so depending on what level of impairments they have, right, based on the symptoms and behaviors, we can conclude, is it low risk, moderate risk, and high risk? And depending on which level of risk this individual present, we'll take appropriate level of actions to assist that individual. So I know I went through very quick through this PowerPoint or this training. I want to leave this up now for a little bit of Q&A. If anyone have questions, I know there's a few. Let's see.
Is it possible for you to go back a slide for that, your risk assessment?
Yes. Okay. Okay. So Eric asked if I can elaborate on the analogy of humility and rapport. So for me, when in crisis or even in interactions in general, in clinical setting, I oftentimes plays the role that I don't know, because unless I can confirm that I know something, I will assume that I don't know. And so the techniques that I use is either, okay, help me understand when you say this, but I observe this, it's not congruent. Help me where there's discrepancy here. And I use that situation for when individuals are saying one thing, but they're behaving something else, right? And so that part of me then help the clients. Sometimes I would confront them in a way that they don't feel they're being confronted. Right? I'm not telling that they're lying. I'm telling them that what you say and what you do, what you present, is not congruent. And so it's either I'm confused or whatever that you're saying, I don't understand. And so that's how I use that technique to be able to help clients, either if they are lying to me or manipulating, and that has happened many times in the crisis setting for individuals who want to be hospitalized because they either don't want to be on the street, they don't want to have a place to stay, or to the point where I have clients who hospitalize themselves, right? They made a statement that they want to kill themselves, so police took them to the hospital because they were trying to run away from the mafia, because that individual has gambling addictions and was owing money, and the mafia went after him to the families. And what was particularly interesting with this case was because the mafia found out where he was at and actually went into the inpatient hospital to visit him and talk to him inpatient. None of the nurse or the medical staff knew about it because none of them understood Vietnamese. And so that's to go back again to the language aspect of it, right? And so that's to understand the individual was terrified that this two mafia individuals, man, was able to find and go inside. And he was too afraid to say no because the mafia guys, we're gonna kill your family if you don't let us in and talk to you. Right? But none of the staff understood what was said until when I came on my shift, sitting in the nursing station, overhearing the conversation. I was like, what the heck is going on? Right? So those are things that sometimes people have ulterior motive to be able to want to get hospitalized, as well as facility who has ulterior motives to try to get a patient hospitalized so that they can get a bed open, or they can want to evict someone from the house or from a program, or even to the point where law enforcement would hospitalize someone because they don't want to deal with them anymore, rather than they actually meet the criteria. And so those are the things that code of ethics has to guide us. When we hospitalize someone, we are taking away their civil right. And so if they don't meet the criteria, that should not be about convenience. That should not be about profits, right? And so hospitalization is something that's as myself and those who have escaped for freedom, value freedom greatly. And so to see someone's freedom get taken away, the civil rights get taken away because of someone's convenience, for me, that's not only unethical, that's illegal. And so any other question? I'm sorry, I kind of went off tangent a little bit there. Okay. So these are the resources here for the presentations. Oops, how did that happen? Okay. So if we can run the post survey, and then similar to the pre, if you take a few minutes just to respond to those post survey of what knowledge do you feel you did obtain, what skill did you acquire. I had hoped this would be in person so that we have actually time to demonstrate and practice the skill set. Hopefully soon we can have more in-person training. And then attitude. And I hope that I have instilled in you certain attitude that's important when we do crisis response. If you don't want to do crisis work, please do not get in it. Because if we are meeting someone who are in the most vulnerable state, and if we don't have a heart in it, right, there are chances of us hurting ourselves as well as the individuals. And not only that, we are ruining it, we're hurting for the rest of the mental health field or the healthcare field, because that person will no longer trust healthcare worker, because individual who come there did not come with compassion, did not come with generally wanting to help them. So if you can, I know at the end, CalOptum will also have an evaluation for you as well. Please complete that so that CalOptum will know what kind of training you want to attend in the future. If this training and the modality and the topic is something that you're interested in, it's something that could be helpful for the organizer to plan and support providers in the futures. And then if anything I can do to assist you with training or crisis work, I'll be my best to do. So this is my contact information. My email address here, Instagram, LinkedIn, and Facebook are all the same hashtag. And then here's the QR code for those. I think this is a QR code for the agency. But feel free to contact me, email or any form, and then I'll do my best to assist you. And then we have about 10 minutes left. I'm wondering if anyone has any question or any cases that you want to explore that we can just briefly go over.
I have a question, Paul.
Yes.
Considering your previous story earlier about having to work a lot and deal with these heavy situations, what is something that you do to prevent burnout or to mediate burnout?
Thank you. That's a great question. I'm not sure if I am the oddball in the room. I find myself either I'm attracted to crisis or crisis is attracted to me. When I left the CAT team in 2019, I had thought that I'm done working in crisis. But in my private practice and now my agency, we have crisis here almost on a weekly basis. We have a contract with the county and DD Hirsch to support those who are survivors of suicide. At the beginning of 2021, 2022, we have call from community members, from Vietnamese community members, who has family members die from suicide every day, almost for 2 or 3 weeks. And so our office was overwhelmed with a call for support from Vietnamese family members who were impacted by the death of individuals due to suicide. As myself, I find this is my vocation instead of a career path. This is my life's calling. What I do here continue to feed what I do because I have my own journey. I have attempted suicide 3 times in high school. I've gone through depressions. I have lost 3 friends. I've lost my best friend in high school from suicide, one of my great friends. We studied together in Japan in my senior year and in my college year. And I've lost my partner, my officer partner to suicide when I was working with PERT. So I have this commitment to help end suicide, prevent crisis as much as possible. So, and that's in terms of my own passion in this area of work. In terms of self-care, I have my families, I have my boys, my 2 wonderful boys that I play basketball with, my sport, my music, my church, my faith. And of course, to do the work that we do, I highly encourage everyone to build that support system. Support system, well, we need to have at least 5 support systems. The more, the better, of course, because no one is available 24/7. But I can confidently say that on my list of support system, I can contact my support system anytime in the day. And that allows me the comfort that if I ever need to reach out to someone for any of my needs, I have someone there who's available to me. And then finally, mindfulness, meditation, and spirituality is my grounding, it's my center. And so when I raise up my challenges to God, to prayer, it uplifts me, because it doesn't matter how much education I have, how much training I have and experiences I have. Every case that I deal with, I treat them as unique cases, and I'm still human. I am still impacted by the experiences of life. And so in that session, in that interaction, I pray that God guide me in my work. And so what I do is for the best interest of the individuals in front of me. Thank you for your question. Any other question? Yes, Adam.
Yes, hi Paul. Thanks for the presentation. My question would be, if you find yourself being kind of, what's that word you use? Being the internal bias or the trigger to a client or an individual, what are the best ways you find to either pass the situation on to someone who might be better involved or take a step back from that situation?
Okay. Thank you, Adam. That's a great question. I've dealt with this many times, and in the training, I share people the techniques the same thing. With the implicit bias, it's a lot easier to deal with than the others, in my experience. Because with bias and with stereotype, right, it's a generalizations of individuals. So oftentimes when I go out to individuals, they will say, "Oh, you're a social worker. You're useless. You're the same as everybody else," for example. Or vice versa. I have staff who use or former staff who work with clients who experience drug addictions or the chemical dependency. We have to change our mindset. We have to help the individuals change their mindset from the interaction. And one thing that I do when I say with other individuals who may have implicit bias against me, whether it's being Vietnamese, being Asians, or being a clinical social worker, I will share with them, I will ask them that I will first acknowledge them that from what you share, that you have had negative experiences with other individuals who have came to try to work with you or try to help with you. And those past experiences that you have had were with people who may have the same background as me as a social worker, or may have been an Asian person or a healthcare worker. Have you met me before? Because this is my first time meeting you. So can I invite you, can I ask you to treat me as this is your first, and it is your first experience, just as I will treat you as my first experience with you. Because I can imagine you also experience the same stereotype, whether you're homeless, whatever that may be, right? People will project those stereotypes on you, and I'm sure that's not true to you. So I would want to treat you with the utmost respect and dignity, and I want to get to know you for who you are, and I invite you to get to know me for who I am. Are we okay to proceed with that? And so that's how I would do it.
Thank you.
Yes.
Thank you, Paul. This is Carmen from CalOptima Health. If it's okay, I'd like to just say one or two things as we close out today. Paul, any last thoughts or reflections before I do that?
No, thank you very much for this opportunity. And thank you everyone for attending. And I hope that the information I share with you is relevant first and foremost, and can be useful for you in your daily work.
Thank you. And Paul, on behalf of CalOptima Health and all of the attendees, we thank you so much for presenting today. And then I just wanted to say also to all of you that attended, thank you so much for joining us today. And whatever your role is, whether you are a provider, community member, thank you for all of the effort and the work that you do in the mental health and recovery space. And I would like to give a big thank you to our CalOptima Health Behavioral Health Integration team that helped put this together, along with Paul and the other CalOptima departments to put this together. And a special thank you also to Dr. Titi Nguyen for the introductions to Paul to speak today. Thank you, everyone. I hope you enjoyed it. And please fill out the post survey and we'll wait for the information after this webinar to be sent out. Thank you very much. Goodbye.
Goodbye. Thank you.